TopMedTalk.
Welcome to TopMedTalk. This piece comes from our live coverage of Anesthesiology 2022. It is the single largest gathering of anesthesiologists in the world and the annual meeting of the American Society of Anesthesiologists. Now, our live coverage is available now at live.topmedtalk.com. More details in the show notes. Don't forget to subscribe, and please help us boost our signal by sharing this podcast wherever and whenever you can. Well, hello and welcome to TopMedTalk. It's Anesthesiology 2022 here in New Orleans, Louisiana. We are in the exhibit hall, booth 2245. I'm Desiree Chappell, your host today, and joined by my co-host, Professor Saul Aronson. Hello, Saul. I almost said Saul Monty. It's weird.
Get that together.
Yeah.
Good to see you, Desiree. Good to be here. New Orleans Anesthesiology annual meeting.
What could possibly go wrong? It's been fabulous so far. We've just been on the ground for less than 24 hours. It's been great. Anesthesiology 2022, one of the largest anesthesia meetings in the world. So excited to be part of this organization and be part of the exhibit hall during the meeting, the American Society of Anesthesiologists General Meeting. Now, so we wanted to take a moment to thank all of our sponsors to make this happen, because TopMedTalk is a free, open, global podcast to the world all about perioperative medicine and perioperative care. And so it's, only through support that we're able to do this. And we have listeners from all over the world that listen to our podcast. And so Edwards Life Sciences, Medtronic, we wanted to thank them. We also wanted to thank the ASA.
Special shout out to the ASA.
Special shout out to the ASA. We could not do that with them. All this booth is because of the support that they have given us to be here. So thank you very much. It's really with my pleasure that I introduce our next guest from Heron Therapeutics. We have Michael Matthews, who's the Senior Vice President of Acute Care for Heron, and we have Dr. Randy Robbins, who's the Managing Partner at Valliant Anesthesia Associates. Gentlemen, thank you so much for joining us. Now,
Thank
Michael,
you for having us.
Yeah, absolutely. Michael, tell us just a little bit more about yourself and your role at Heron.
So I'm the Senior Vice President of Acute Care, so responsible for the Acute Care franchise. We currently have 2 drugs. One's already on the market. It's called Zinrelief for postoperative pain. And we just got approval from the FDA for a postoperative nausea and vomiting drug called P.O.N.V.
It's called
P.O.N.V.
P.O.N.V. Well, how very appropriate. Wow, that's great.
Thank you.
Congratulations.
Thanks.
That's awesome. Dr. Robbins, why don't you give us a little bit more about your background?
So I've been a private practice anesthesiologist in the Dallas Metroplex since about 2003. I founded my own practice in 2013, Valliant Anesthesia Associates. I've worked closely with some of the folks that have been with Heron, on the launch of Zinrelief, and then as an anesthesiologist, obviously very excited about the treatment for postoperative nausea with the P.O.N.V. So I think hopefully we're going to see some real change in the perioperative landscape with pain and P.O.N.V.
Absolutely. Well, just to set the stage just a little bit, we'll start with P.O.N.V. I know some recent guidelines came out, I guess recent, it feels recent, back in 2020 for management and prevention of post-op nausea and vomiting. Right now, for our listeners and people watching, tell us about what it really looks like in practice right now for rates of P.O.N.V. and is that still a problem that we're actually dealing with? Well, many people think that it's
Rates of P.O.N.V.?
Yeah, rates of P.O.N.V. have actually gone down, and we don't have to worry about it so much.
Well, from our experience and the research that we've done, we see about 30% of patients require rescue treatment.
All comers.
Even if they've gotten prophylaxis beforehand in some cases. But even more concerning is there's roughly 12 million patients that receive no prophylaxis, and these are moderate to high-risk patients currently. So there is an unmet need, a pretty big one.
Yeah, absolutely.
Yeah, I would say I have a full clinical practice. I probably do, 50 cases a week almost. We're pretty busy in T practice, and I get asked multiple times a day from patients, listen, I throw up every time I have anesthesia. Yep. So it is hands down the number one concern of patients. I mean, it's their biggest concern over pain, over recall, over IV pain, everything else. They do not want to throw up. Yep. And the problem is the treatment for nausea is just such a challenge, and really nothing we have does what we think, a P.O.N.V. will do.
Yeah. Well, and we're going to get into the post-op pain in just a moment, but tell us a little bit about a P.O.N.V. and how it works and when you use it. I know it was just approved, but a lot of people, there aren't a lot of great rescues and there aren't a lot of great treatments post-operatively. So tell us just a little bit about that.
Well, a P.O.N.V. was approved for prophylaxis. It's the first IV substance P NK1 receptor agonist. It's given in an IV push. So it's really something unique and different. There is an oral version, but this can be given really right before induction. And it has a rapid onset of action. So it reaches 97% receptor occupancy within 5 minutes, which is really differentiated from the oral, which can take 3 to 4 hours to do that. So physicians will know that it's on board when the patient's done with surgery and working. And it's also, Perioperative is it's been seen as the most effective drug, either as a single agent or in combination, for vomiting. And the drug works for 48 hours, so it's great for outpatient surgeries.
Yeah, fantastic.
So just to drill down a little bit on the pharmacokinetics. So onset rapid, 5 minutes, IV push, and it has a duration of, it's beta half-life of 48 hours?
Yeah.
Terrific.
Half-life's 12 hours, but it
12
goes
hours.
out to 48 hours of treatment. Yeah.
Okay.
Fantastic. And this is something, when is it recommended that you give it, I'm sorry, I might have missed this, an induction towards the end?
Just prior-
is there any
prior to
recommendation?
induction.
Prior to induction.
Yeah, and I think you'll see people give it a lot of different phases in the perioperative space, because I can speak as a provider and as a patient that has significant P.O.N.V. myself. This drug works. I mean, a Prepitant, I've had 3 surgeries since Amend has come out, and it works. And so, but having the struggle with the oral version is the challenges of getting a patient a prescription the night before, getting it filled, and having them actually remember to take that 2 hours before they show up to the morning of surgery, on top of everything else they've got going on, it's highly unlikely to really get a good penetrance there. With this, we can give it in the pre-op area, we can give it in the OR, we can give it lots of different spots, and help really get the patients comfortable, not just in the immediate post-op phase, which is a much easier space for us. Yeah. But the biggest thing is when they go home, it's that car ride home. It's when they get home and they have nausea and vomiting for another 6 or 8 hours that really frustrates the patients and makes them feel like the provider didn't really care about what happened to them after they got home. Yeah. And we do, but we just don't have great options for that, and I think now we do.
Yeah.
And if I could go back to its pharmacokinetic profile, the fact that it has an onset of 5 minutes, and you said its indication was prophylactic. Do you have a rescue indication as well?
No.
Okay. One would think with an onset of 5 minutes that would be intuitive.
Well, it is. We followed a 505(b)(2) pathway to get the approval for the drug. And if you look at antiemetics, there's only one that has a rescue indication. Mm-hmm. So every single antiemetic is used in both stages by physicians. And so it'll be up to the physician to make that decision where they think it's best suited to be used and when and for which patients.
Yeah. This really sounds like it could change the landscape
100%.
For our patients and for providers, to have another tool in their toolbox for this. In the context of kind of, looking at risk scores and then determining how many different meds, prophylactics that you give, is this just going to be another one that we use? Is this going to be a primary kind of prevention treatment, or where do you think that this is going to go?
I think there's going to be a lot of learning curve with this. I think it'll start off as probably more of an add-on, because I think people are unlikely to totally walk away from what they're giving now. Over time, I think we may see that it'll be nice to have this drug as potentially a primary on the front side, so that we do have an option to treat if we have breakthrough nausea, because again, nausea is the hardest piece to attack. This really does a great job of preventing vomiting, which is the most concerning part for patients. They can survive a little bit of nausea in the post-op period. It's the vomiting after their thyroid or their tummy tuck or anything that they just scares them to death. So I think this will give us an option to hopefully eventually start looking at this as a primary preventative, and then allow us to use some of those others for rescue nausea if we need to.
Right. And we can use this across the board. Are there any contraindications to the drug? Is there anything that we should be concerned about as providers using this?
There is a contraindication with Pimozide. It's a drug that's used to treat Tourette syndrome. But
I was going to say.
It's pretty limited. Yeah, I mean, you're going to be able to give it. And we don't have a pediatric indication yet.
Okay.
So I think that's the piece that'll come.
The drug has been used extensively in chemo-induced nausea and vomiting, so it has a very safe profile.
Yeah.
Fantastic. Well,
no
that is great
QT
news.
prolongation or anything like that. So really no CV side effects with that. I think it's a very, very clean drug.
Yeah.
Yeah. Oh, that is so wonderful to think that we're going to have, again, that other tool in our toolbox that we can use for providers. Because in a lot of people, I think, also messaging that this is still a problem for us. In anesthesia, a lot of us drop our patients off, head to the next case, and we may not see see everybody in post-op, and we definitely are not seeing them at home. Yeah. So the fact that we have something that we know we can definitely take care of our patients, I think will be awesome for sure. Well, let's switch gears just a little bit to pain management. This is a very hot topic in anesthesia for sure. And I know all of us are always searching for ways to treat pain for our patients. So tell us just a little bit about where you guys are with this new medication.
Well, we launched it last year, ZYNRELEF, and ZYNRELEF is the first dual-acting local anesthetic. It's a combination of bupivacaine and a very small amount of meloxicam. And the reason that the meloxicam is in there isn't for analgesia. It's because of the unique mechanism of action. What it does is it helps bring the pH back up in the wound site that's caused by inflammation, which allows the bupivacaine to continue to penetrate the nerve cell. Because once the wound becomes acidic, bupivacaine ionizes outside the nerve cell and therefore is ineffective. And so this is why the drug lasts over 72 hours, and it's the first drug ever designated in the local anesthetic space by the FDA as extended release.
Interesting. That is very interesting. So regional anesthesia being, again, the hot topic in our space, where we're going with this, different medications available. Where do you see this fitting into the regional? Is it different types of blocks? Is it you can use it anywhere? Is it specific? I mean, what is the approval that you have for this?
So ZYNRELEF is applied directly into the wound site at the end of surgery, but it can be used in conjunction with nerve blocks so that physicians can decide to do both if they want to manage their pain. But it works over 72 hours. And maybe you can comment how you're using it.
Sure. Yeah.
So it's field more than it is for regional to use.
It's 100% field, yeah,
Okay.
and that's the one oddity with anesthesia in this drug.
It is.
It's a drug that we never touch.
Yeah.
I mean, I guess we could hold the vial while they aspirate, but that's the only time we'd see it. So it's not really used in blocks or anything. It's really, I say it's C-pain place drug. So it's really up to the surgeons to kind of to instill this drug, but it definitely has to be a part of a perioperative pain protocol.
Yes.
So I think doing preemptive analgesia with blocks and stuff, like we've always done, but it helps us do something on the front side that's maybe shorter acting, allow this drug to do what it does on the post-operative period. It gets rid of catheters, gets rid of long-acting liposomal that may or may not work after that first 24 hours, and really gives us an option that hopefully will start seeing a reduction in opioids, in the perioperative space.
So though the anesthesiologist per se doesn't touch the drug in terms of administration, I think you raise a good point, and just to sort of touch on that and expand. A part of the entirety of the plan, if you will, the perioperative, process of whatever we may call it, enhanced recovery or what have you. The anesthesiologist has a role to sort of raise their hand in the room and say, hey, we should include, this pH, if you will, adjusted, opportunity to expand the duration of this drug. How do we, shake that tree? How do we get on the mountain and sort of speak to that?
And I think a lot of that comes down to surgeon relationships and facility relationships. Just being able to talk to our surgeons and say, hey, there's a drug out there that I can't use, but you can, that can fit inside our kind of entire protocol, that we can still do your preoperative block so that your pain during the case is minimalized. But then you can put this in and we can get 72 hours. You're not going to get phone calls from catheters. We're not going to get phone calls from catheters. You're not going to have to worry about, block creep up, especially in the ductal canals or anything. You're not going to worry about weakness. You're going to have a whole different, safety profile and options for especially total knees and stuff than what we have right now.
So the next question, good point, is how do you envision this tipping the balance of catheters and longer term, if you will, processes to keep the analgesia going? Will this reduce our need to use catheter-based tools?
I think it could totally replace catheters because it literally will last 3 days. You don't have to worry about phone calls. You don't have to worry about, even the best catheters, if they're working, I had one when I had my ankle surgery done. They work and they're right, you still make phone calls. And I knew it was going on. I still called the girl that put mine in and said, hey, I think you bagged my nerve.
Right.
Sure, that's what it's planned.
On the other side of that, we've had a great partnership with anesthesiologists.
Right.
They're at the center of pain management. They understand the value and the mechanism of action, how the drug works, and they're quite good at explaining it and finding the right place for it to be used. And we also partner with surgeons so they know how to apply it correctly, et cetera. But it is part of that multimodal analgesia that you're going to be doing for the patient to get better pain relief as they come out. And we've seen all kinds of great things. We've seen reductions in opioids. We actually were the first people to do a trial where we had an endpoint that said how many people could be opioid-free after surgery, and we showed a statistical significance versus the standard of care bupivacaine. So we are starting to do things that are going to really help change that landscape in terms, especially in the outpatient surgeries, where you can reduce the necessity for an opioid prescription.
Mm-hmm. So when you say you compared the two, you were looking at opioid as bupivacaine as a field block, or did you look at regional anesthesia versus?
The majority of bupivacaine is used in local administration, not for nerve blocks.
Right.
So that was the comparator in the trial
Great.
that we did, and we showed superiority on pain.
Great.
But we also looked at severe pain and showed superiority there, and not just over 72 hours, but at 8 and 12 hours when bupivacaine is most effective.
Yeah.
We also looked at reduction in opioids, but we had a unique endpoint in a significant increase in patients that were opioid-free, required no opioids over 72 hours, and that's without rescue medication. They had to ask for it. So that was pretty unique in our trials, and we hit all those endpoints.
That's great. And did you look at opioid use during surgery well? As when you say opioid-free, is that for the entire perioperative?
Not interoperative.
Not necessarily.
That was allowed by practice and how physicians are doing it today.
Sure.
Well, and I think one of the most impressive pieces was the HOPE trial that really came in and showed, because the first studies really just looked at ZYNRELEF itself. How does this drug compare to the current standard of care? And I think it showed its superiority. Then when you start coupling it with a multimodal in the postoperative period, even things, ibuprofen, acetaminophen, things like that, we saw a massive reduction in opioid utilization. And the bulk of patients were going home without an opioid prescription and stayed opioid-free through their entire recovery.
And zero callbacks.
Yeah, and if they went home without a prescription, they never called and asked for a prescription. And I think a big piece of that, almost like P.O.N.V., it's us stepping in as patient educators and kind of starting to set the stage of, I understand that, your best friend had her knee replaced, 4 years ago and got 400 Lortab 5s.
Yes.
You're not going to have that anymore. We've got better options for you, and you're going to get 15 Lortabs 5 for that rescue treatment over the first, week or two, and then you're going to do well. So I think the same thing with that education and the P.O.N.V. education, I think will really go miles.
And it makes a big difference because if you can, and in the HOPE trial, 91% of patients, they got no prescription, 95% were opioid-free after surgery through day 15 recovery. If we're reducing the amount of opioids that we're sending home with people, that means less unused opioids in the medicine cabinet.
Diversion.
But it also means we're exposing fewer and fewer people to opioids, which is a very good thing in this country.
Absolutely. I mean, it is a major push for that from, the top down to make sure we're looking at this. And this is a great, kind of a great option to help us do this. It's great.
Well, I don't think anyone saw, obviously when they made pain the fifth vital sign decades ago, they never kind of had the forethought to say, wait a minute, we're putting physicians in a really bad spot. Yeah. Because if we have patients in our current environment that think they should come through surgery pain-free, it's unrealistic. Yep. And that's what they expect. I mean, they expect they aren't going to throw up, they aren't going to have pain, and we honestly just can't provide that. And it's it's led to this opioid crisis, and the problem is it's just a different war on drugs that we're looking at. Yes. We're not trying to stop mules across the border. We're literally taking drugs out of my medicine cabinet, your medicine cabinet, your kitchen cabinet.
Yeah. And it's a habit that we're going to have to break as well. For our own habit of prescription.
Well, look at the opioid crisis in the COVID. I mean, people sat at home, and what they do, they used what was available to them at home. They weren't going out to street corner dealers. They were just going to their medicine cabinets to escape.
Yeah, and we saw with COVID, the opioid crisis sort of lost the spotlight. Now we're paying for it, right? And a lot of people who develop opioid use disorder get their first exposure from leftover pills from friends and family. Yeah. And so the fewer of those that are around, the better. But also the fewer people that need pain medication, because opioids have a role to play. They really do, but it shouldn't be first-line therapy. It should be third-line therapy. Yeah. And so if we can prevent people from getting there by reducing severe pain, it's a big deal. Yeah. It's really something
I love that.
Unique.
It is really a big deal. So I would imagine lots of education right now because, me as an anesthesia provider sitting down, I'm going to have something else I can do. And then it's like, I can't use this for regional, but what do I do? How do I build this in? And very familiar with enhanced recovery protocols, multimodal pain protocols. Let's break down the education for anesthesia providers. What else are you guys doing to get the word out there? Is there, resources that we can check or the study? You mentioned a couple studies.
We have all kinds of resources. We've done a lot of studies. We continue to do studies. We're working on expanding the indication currently with the FDA, which will be submitted at the end of this year, early next year. We have materials for anesthesiologists as well, where they can look and say, hey, if we're going to do regional blocks, if we're going to give a nerve block, here's the total exposure of the amide, so they know how much they can do and how much to give, because the drug releases very consistently over 72 hours. So it's very possible to use it in conjunction with other multimodal approaches.
That's what I was going to ask for, like, the table of where I'm, not having to do math in the OR is great as much as possible. So that's wonderful. Okay, how about surgeon education? Because again, we've talked about a lot of challenges. One, it's coming from the anesthesia provider, so I need to, have everything ready to go. But also, when it comes to knowing the duration of action and I don't need to send pills home, what kind of education is out there for maybe us as anesthesia providers to share with our surgeon colleagues?
I mean, I think, again, it goes back to those conversations, those relationships. I mean, we have to have the knowledge ourselves first that we can share with them. And then, I mean, they have an entire staff of folks from medical science officers and reps that can step in and kind of lead that conversation for them. I get calls most week from somewhere in the country, asking a question about blocks with this drug or anything. How can I have a surgeon call you? Can I have an anesthesiologist call you? So I think there's a lot of interest in the drug itself. And it's the first drug I've seen in 20 years that I think truly has the potential to shift the paradigm in perioperative pain control.
And we're working directly with surgeons, too, and we're talking to them about educating their patients up front. This was a big deal in the HOPE trial as an example, to really tell patients you should expect pain, especially if a total knee replacement. It's not going to be pain-free.
Yeah.
And so pain can also be a good thing. It lets you know something's wrong. Okay, it lets you know to be careful. It lets you know you're healing as well as it goes away. And so that's all good. We also are working with them to schedule non-opioids, acetaminophen and ibuprofen, and remind patients they should be taking these drugs on a regular basis. And then if they do prescribe only opioids, only as needed, perhaps to sleep, etc. And so what we've seen that physicians can be hesitant at first to change their practice completely, but as they use the drug, they've significantly reduced that necessity of giving or prescribing opioids and reduced the amounts by quite a bit.
Can I ask for or I'd like to request some education or maybe a tool, an infographic that actually is a patient handout that has the schedule for if you start your Tylenol here, then take your, because that is actually very, very difficult. Great. That is wonderful. It truly is. I've worked in this space for a long time. It truly is difficult for someone to wrap their mind around it, especially if you don't have kids, because as a mom, I know how to do it, but my grandfather didn't whenever he had surgery. So I think that's really great. And then patients, how has this worked? Tell us about the feedback that you've gotten from patients and the providers that have been using this drug.
Well, why don't we ask this provider first, and then I can give you some other ones.
And again, I think we've seen that it really, really makes a difference. And like I said, we don't use catheters in the bulk of our patients anymore. So we've really gone to single shot blocks. We've gone away from liposomal and really just worked on single shot blocks on the preoperative side, coupled with ZenRelief intraoperatively. And I think the patients, there's still struggles with getting in on it at formularies and different things, but we're seeing a lot of headway on those, and surgeons are very excited about this opportunity. So I think, and patients have done very well. I mean, we don't do a lot of follow up, as you said, with anesthesia, but from our surgeon friends, they say that really the pain control has been very, very impressive.
Yeah. The biggest word that we hear, or that I hear, the feedback they get is game changer.
Wow.
So when surgeons start using it, they really see that it makes a difference. They're seeing better ambulation with patients after surgery. We've had, it's not published yet, but it will be published probably by the end of this year, a large trial that showed significant reduction in length of stay. And this is versus other things that are being used, like cocktails, in the marketplace today. So they are looking and they're comparing, and they're seeing a significant difference by using ZenRelief in their surgeries. They've also been able to significantly reduce the amount of opioids that they're prescribing, and they've gotten more patients that are truly opioid-free. We have, in certain surgeries, there are physicians who've stopped prescribing opioids after surgery, and then they'll wait if somebody calls back, and that's maybe very infrequently.
Yeah, great. Well, if people are here on the ground in New Orleans, where should they find you in the exhibit hall?
We're right over there. The booth number slips my mind right now, but we're close to the Medtronic booth.
Right over there.
330. 3327.
3327.
Yes, that's why we have everyone here.
I should know that.
It took me a long time to get my booth number. But you are in the exhibit hall. It's a beautiful booth. Please do check it out. Is there any other resources or ways to get more information for providers?
Well, you can go to ZenRelief.com and Heron, of course, .com, and check us out there.
Yeah, fantastic. Gentlemen, just in closing, how do you feel that these two drugs are going to change the acute patient setting?
I think for me, it's going to make a world of difference. Like I said, if we can get 15 or 20 more patients out of every 100 that don't experience vomiting in the postoperative period, that's life-changing for those folks. And I think it will be a massive, massive improvement on what our current options are. From a postoperative pain control, again, if we've got 3 days of pain control with a drug that's really, we've had no instances of last or anything, so there's really
great.
The option, the opportunity for toxicity is so low. Yeah. Even coupling it with blocks, I think it's truly going to shift the paradigm over the next year or two.
Fantastic.
And for us at Heron, I mean, we truly believe that, if we can create a better option for patients and healthcare providers, it'll certainly get used. But all of us are going to face pain at some point in time. All of us are going to go through surgery and have the risk of P.O.N.V. And so if we can create better options there, we're helping everybody across the board.
Yeah.
So.
Oh, fabulous. Gentlemen, thank you so much for taking the time to sit with us today. From Heron Therapeutics, we appreciate everything that you're doing in this space. We will definitely be looking for other indications and check out those studies as well. We'll put all of that into our show notes for TopMedTalk for the podcast, so all those will be listed.
Thank you.
So great. And thank you for listening to TopMedTalk here at Anesthesiology 2022. We will be right back with our next conversation. Cheers.
TopMedTalk.
Do check us out for our live stream from Anesthesiology 2022, live.topmedtalk.com. You can hear all of our amazing conversations live during Anesthesiology 2022. You can find the schedule for all of those at live.topmedtalk.com. Cheers.